This segment, it might seem kind of dry or kind of technical or a little nerdy, but that's the kind of stuff that we like. But it's practically actually really useful to think about how claims, right? If, as Beth was saying, how claims and the payment of bills, right, gets turned into a research file. And so that's kind of what this segment is about. And the thing is that along that pathway from the payment of bills, the submission and payment of bills and their processing and their payment, all the way to internal data repositories and research files, there are things that happen to the data that they don't exactly break the link between the real world and what's in the data, but they do change that link, right? And so it does shape to some degree what researchers get. And so it helps to kind of understand when you're looking at the different files, and it's important to remember when we say a particular file, a lot of times each file has multiple segments, as you'll find out. But as we look at each file, we need to think about, okay, that file, that's that shape, that has that content because of the source and processing. All right, so and we do have time for questions at the end. If I can track them on the chat, I will. Otherwise, we will try to get to them at the end of the segment. So we're going to look at what's a claim, how are they processed, what is the repository that they go into, and then how are they shaped into data files. So we're going to kind of remind you about this again and again, because it's important to remember that, if you're thinking from a research standpoint, you can think about issues like measurement error and bias, right? And those come from a lot of different places, but in these data, one of the places that shapes that data generating mechanism that can shape things like missingness and bias and all kinds of other things is the fact that these claims are bills for services and supplies, right? And so they're provided to a particular population under Medicare. As Beth said, these are not created for research purposes, at least initially. They don't exist because of research initially. So knowing how they're processed and paid, it is an important step in kind of understanding what to expect in the files, as I mentioned. So there are a couple of different claims forms, and these are actually, this sounds kind of technical or dry, but it's actually going to be really relevant to the shape that the files take in the end. So CMS collects them on these two different forms. One is the UB04 form, beginning in 2007. A good way to remember these is actually probably the electronic form, because that's often, I think, how these are actually submitted much of the time by billing departments and so on. And that's the 837I, okay? And if you think I, think institutional. Then there's also the CMS 1500 form, beginning around the same time. Now that electronic form is the 837P. And I'm gonna guess and say the P is, you could think about it as provider. So 837I institutional, 837P provider. They'll start to give you an idea of how these things shake out in the data files. We do have forms and instructions at these links, and actually, in our ResDAC offices, we do have all kinds of billing guidance books and documents and things like that, because for us it really does help to understand when we're trying to answer questions. It really does help to understand exactly how health systems might be submitting these. And we actually do sometimes even reach out to billing departments and things like that. So these are the kind of the paper forms. And you can just note that, if you think about a data file as having a number of different fields with information in them, right? If you think of data documentation, those fields are populated by information that largely comes from these forms, but not completely. So UB04 is the only form used by institutional providers, and those are those that provide services covered under Part A, which Beth was talking about in the previous segment. The thing is that some of these institutional providers, like hospitals, may provide services that also provide services that are covered under Part B. But the key thing to remember is that they provide those Part A services. If they provide the Part A services, they're billing using the UB04 or the 837I for institutional. So providers of Part A services only, we saw like about 4 categories of those that provide Part A services. Well, 2 of them, usually you're only going to see just the Part A. So you got skilled nursing facilities or SNFs, and you have hospice. But we also have providers of Part A services that sometimes provide Part B, right? And so then we have hospitals where inpatient is Part A, but outpatient, hospital outpatient, is Part B. And when I say outpatient, think hospital outpatient, not all services, because there are other types of services that we're going to look at in a second. So this is hospital outpatient is Part B. We also have home health agencies, right? So some only provide Part A, some provide both Part A and Part B. But the key feature is that they provide Part A services, institutional providers, 837I. So who won't? Well, that means that if Part A is the defining feature, then you need to think about, okay, who doesn't use that? Who uses the CMS 1500 or the 837P? And this is why I like to use the term provider, because a lot of times we're thinking of non-institutional providers like physicians, nurse practitioners, ambulances, and you've got the list here. A standout here would be the durable medical equipment or DME, which you'll see why in a second. But so these are ones where they only provide that service. And what's really interesting is that in some cases, some of these categories are a little bit mixed. So I'm going to pull out ambulance services as an example. Ambulance services, sometimes you'll see an ambulance go by and it's got the name of a health system on it. Now, I don't know exactly, I haven't dug into this yet, but we have looked at how ambulance services show up in the files. And what's really interesting is that if you were going to get a picture of ambulance services that is as comprehensive as you can be in Medicare Fee-for-Service, you would actually want to look at an institutional provider like a hospital that's providing a Part B service, right? So you can have it in that hospital outpatient type space, or it could be a standalone ambulance service that is a full standalone and fully non-institutional provider. The interesting thing, of course, is that those end up actually being billed using 2 different forms, right? One is the institutional provider using the 837I, but the standalone is using the 837P, right? So if you were going to look across ambulance services, if that's your interest, you actually would need to look at a couple of different kinds of files because of how they're processed. And that's an example, again, of why I'm saying knowing how they're processed actually tells you why you would want to look in one location or another or both. So these are processed by MACs, or Medicare Administrative Contractors. And I will tell you that this is not some secret. CMS has a website, has a website that actually gives you all the information about MACs. So if this is interesting to you, there's plenty of information that CMS actually already has on its website. So we're just highlighting things that are definitely publicly available. The thing is that there had been more processors, like several more, and they were of multiple kinds. Well, now we really only have 2 different kinds of MAC jurisdictions. So we used to have home health and hospice as a specialty, but now they're actually integrated into the A and B MACs. And then you separately have the durable medical equipment, right? And so right now, what we really have are just 2 different kinds of MAC jurisdictions primarily. And so we can show a map here. So these are the AB MAC jurisdictions across the country. So you can see they're regional, they cover certain states. The DME ones, I don't have the map here, but it is available at CMS. And basically there are 4 MAC jurisdictions for DME. And those are covered by, I think, 3 of these. I think NGS has 2, CGS has 1, and Palmetto has another. So there are like 4 MAC jurisdictions for DME. I went and looked it up the other day because I was curious. So what the MAC does is it enters the claim into the system. It may edit the claim for consistency or utilization errors, calculate, and possibly deny the claim, depending on coverage rules. So there may be an initial denial by the MAC. Because the MACs exist and because there's a process that happens after the bill is submitted, this is not as simple as saying, oh, there's a clear link between the fee-for-service files and the services that originated to create those bills, right? This process means that the research files do contain some more variables than those that are found on the claim form because there are additional fields that are added during processing. So not all fields on the claims forms are found in the research files. So you kind of, there's a shaping of what happens in the claim where certain things are added or lost, not a bunch, but some, before you get to the research file. Then the MAC sends the claim to the beneficiary's assigned Common Working File Host Site, or CWF. And the CWF has some additional processing that it does. So it may determine whether the beneficiary is entitled to receive the service and whether a deductible applies. Checking for duplicate claims, returning denied claims. So the CWF host site can also return denied claims, authorizing the processor to pay it. And then, so that's all kind of facing backward in the process, but then the CWF host site also sends the paid and denied claims to CMS. And so now we have that kind of updates the entitlement and utilization information into the common Medicare environment, right? And so a lot of that information goes into this internal Medicare repository. So the transmission to CMS from the CWF will update and populate a couple of things. Those include the enrollment database and the master beneficiary database, right? And those feed into the common Medicare environment, as I mentioned. They also will update the claims information, right? So that CMS has those types of information as well in the National Claims History Repository. So these are the kinds of internal data banks where the CWF information is now feeding into the Medicare and CMS environment. So the thing is that having many processors used to introduce variation in the data, right? So if a given processor, if a given MAC, or sorry, previous to the MACs, if a given processor is doing something different than another processor, well, now you have some kind of an outside processing difference, right, that can create an artifact in the data where you see a difference that might be regional or state difference or something that you might be tempted to attribute to differences regionally or state-wise that are real when in fact they are just because of the processing difference. But with the implementation of the MACs, the variation in that claims processing has really been minimized because we have that integration of a much smaller number of processors across the country. And in addition to that, what's really good is, and if you think about if you were going to do a research project, you would have to do a ton of work on data quality assurance and standardization and all of the kinds of data quality checks that you need to do. CMS is kind of doing that for you in a way through its own auditing systems where they have the quality assurance surveillance plan. And the thing is, so that's great. The thing is that we then get to the fact that variations in the data can still occur. The thing is, hopefully they shouldn't be occurring because of processing. So that's a good thing to know. It's a good reassurance. The variations in the data that do occur, though, often require you to have contextual knowledge of what's going on in the policy space, in the legislative space, those kinds of things. Sometimes because of new evidence, CMS will issue a national coverage determination where they actually change what is covered, what is covered under the Medicare program. You may see local practice variations, especially if things are not required for payment. There might be a lot of variation going on in how things get billed, how they're done, and how they're done at first, but how they're billed, how they're then processed, and so on. So there are some variations that are still going to happen, but they often require you to have more of a kind of the contextual policy or clinical knowledge in order to know why is this variation happening. And usually when we see kind of real changes in trends where there's kind of a sharp change, we go looking for things like, did a coding system change? CPT codes, for instance, did they get updated? Was there some change in this particular treatment and what code it's used? And we actually need to look for a new code. Those kinds of things. Was there a law that changed? Because the data they don't usually tell you that themselves. They don't speak for themselves. You need to actually go and find those things out. And so this is just one of many times we'll probably warn you about knowing the area that you're in and having usually multidisciplinary teams to make sure that something isn't missed or that you're not attributing a change or a variation to something that's really happening as opposed to in, let's say, clinical practice when actually there was a national coverage determination issued, that kind of thing. All right, so to kind of put this all together, the idea is that, somebody is sick. And of course, as we know, in order to show up in the data, the person has to actually get service. They have to seek out treatment and get services. So access to care and availability of care and so on also are going to be shaping the data. So that's important to keep in mind. But they see an institutional provider and or a non-institutional provider. And depending on which form they're using, at some point they issue a claim to a MAC, right? And the MAC is then going to do all those things that we mentioned, enter the claim into the system, consistency and utilization checks, etc. They might deny it initially. If not, and they've processed it, they take that over to the CWF host site. And the CWF host site will, obviously return some information and authorization to the MAC for processing payment and so on. But also, again, then it will actually feed that information down into the CMS environments that we talked about. So the enrollment database or the common Medicare environment with entitlement data, as well as the National Claims History Repository. So you can kind of think about all the things that happen to the data from a person actually being sick, or seeking out, and then seeking out treatment as a separate thing, and getting treatment as a separate thing. And then all of these other steps happen. And this is where we can see that, like any data source, there are data generating mechanisms here that will shape the data on their own, regardless of what's happening in the real world. One additional piece to consider here, and this is especially maybe for clinicians, if you've had to click through, say, Epic or some other electronic health record and have entered information. I have spoken with clinicians who were of the mind that basically that information was just kind of transferred straight into a claim. And that's not the case. So usually you do have a medical record, but you have to go through a process, right? So that medical record is not the same as a claim. And that's because we have medical coding. So if you want to fully understand the data, and if you're running into something that doesn't make sense, and one thing that we have done, that I've done on my teams, is we will actually have somebody reach out to a given health system's coding and billing department to actually check and see what codes are you using to submit this claim. And a lot of the guidance, if you go on a search engine and look for particular codes or coding systems, you'll see a lot of guidance in different insurance companies and things on exactly how things are to be coded, right? So it's not a clean link, right, between EHR and the claims. It doesn't just automatically filter in. There is that layer of processing that is not part of CMS's process that is happening even prior to, kind of all this in some of those early stages. And so there's a lot of things that have to happen. In addition, of course, they're not taking a problem list and just writing it, alphabetically into a claim form. They're using codes. They're using coding systems, and there are multiple coding systems. And this is a nice slide we should have updated with ICD-10. But you have ICD system, you've got CPT, and you have HCPCS codes, which we'll talk about. But basically, these are all different coding systems that kind of are used to communicate the information that coding needs to communicate to billing and to CMS. So this additional layer also needs to be considered. So one of the things you might think about is, okay, are there certain health systems that are more likely to code for a particular condition? So I've had people ask me about things that they call social determinants of health. And you could think about something like homelessness. Well, there is a code for homelessness. The question is, do providers code for it? Do health systems code for it? Are there some that are more likely to code for it, right? We have a sensitivity issue, right? And so those kinds of questions do come up, and you need to think, and of course, again, it's good to reach out to coding and billing departments, because that shapes the whole process before it ever gets to a MAC. So the claims files for the researchers, typically we usually say CCW, that's the Chronic Condition Data Warehouse claims files. And there are separately, which I think we'll talk about, is the MedPAR file, the Medicare Provider Analysis and Review file. It's kind of a rolled up file of certain claims. And they contain only final action claims, meaning all adjustments are rolled up into one record. So you don't see multiple adjustments being made to this claim on separate lines or something like that, right? So we do get all that kind of rolled up into the final action claim, including full payment, partial payment, and denial. And there is that, the white paper is actually a good resource for kind of looking at the claims data maturity and completeness and that kind of thing as things get processed. So each file contains claims for services rendered in one calendar year. So you'll have files with the year based on the claim through date. The CCW claim files remain open for 365 days before being considered final. So those final action claims remain open for a year to allow for all those adjustments, and they really are capturing almost everything that's going to happen. So we have 1999 through 2021 annual, and we also have quarterly files into 2022. And I personally had some concerns about the maturity or completeness of the quarterly files. When we've done checks, I've been, I guess, pleasantly surprised that actually the quarterly files do capture a lot. Not everything that an annual file might, but they're actually fairly mature. So I've actually been pleasantly surprised with the quarterly files. So if you're really trying to look at something that's really timely or as close as you can think about the quarterly files also. So here's the interesting thing, is that a hospital does do Part A and Part B services, but you don't have a single hospital file. You have hospital inpatient and hospital outpatient. And I just want to really emphasize for everybody, because I have been on research teams with, let's say, a clinician researcher and a data analyst or a data scientist. And the data scientist, if they're used to using claims, they will use the term outpatient when they mean the hospital outpatient files. Whereas a clinician researcher, when they think outpatient, they just mean anything that's not in an inpatient state. So that includes provider services, it includes hospital office visits, all kinds of things. So it's just a big kind of mix of things, right? And I've actually had to kind of translate when I realized that a clinician researcher had asked for outpatient and they meant anything that wasn't inpatient, whereas the analyst had took that literally and given them the hospital out, and not out of malicious compliance, but they truly, there was actually a missing translation that wasn't happening between the two. And I had to say, no, what they mean is the hospital outpatient and provider services. That's what they're talking about. I had to kind of do that translation. And so I just want to make sure when you say outpatient, when we say outpatient, at least specific to these data, always remember it is the outpatient services provided by hospitals. Okay. We have skilled nursing care, home health care, and hospice, right? So those are all institutional providers. Some of them are submitted on different forms, and so you do end up with that hospital inpatient, hospital outpatient split. So in some ways it's kind of nice, except that can make tracking things hard. Like emergency department visits, especially if they end up in an inpatient stay, tracking exactly what happened in one space or another. You're probably going to need both files to really see what's going on. And you may even need some other files like the non-institutional files, particularly things that cover physician, freestanding ambulatory surgical centers, laboratory, other supplier services like ambulances and all those things. That is in what we call the carrier file, which you'll learn about. So the carrier file is a big kind of mishmash of things that is not as cleanly delineated as, say, the hospital inpatient file. Then, of course, we do have the non-institutional durable medical equipment, or DME file as well. And so if you want to kind of think about this, we have the providers, all these different types of providers. And these are the institutional ones, and they feed into these MACs, into the CWF. The CWF, of course, it is communicating back to the MAC, but is also then populating those internal repositories. And that's where we're getting then the home health, hospice, hospital outpatient. So instead of OP, if it really helps you to think of HOP, and the hospital inpatient, or I guess that would be HIP, and the skilled nursing facility, particularly post-acute stays. And those then, of course, a couple of those do feed down into kind of more rolled up files called the MedPAR files in inpatient skilled nursing. Then, of course, you have non-institutional providers that kind of follow a similar piece here, where you have all those other non-institutional providers in DME going, again, through a MAC, through a common working file host site, which then populates the repository, and that's how we end up with the DME and the carrier file, which again is kind of a big bucket of different kinds of provider services that are not institutional. So, of course, a healthcare service may generate both a UB04 and a CMS 1500 claim if you have a mix of institutional and non-institutional providers. But each research file is constructed from either UB04 or 1500, CMS 1500. There's no research file that's constructed from both types. I'm going to say that again. There's no research file constructed from both types. So to identify claims from one service or one event very often will require you to look across multiple types of claim files. I've seen a lot of people who will say, oh, I just want the MedPAR. I just need the hospital inpatient because it's inpatient service. You know, I'm looking at something that's in the inpatient hospital space. Yeah, but there are probably some, let's say, non-institutional provider like physician or nurse services that also get billed for. And therefore, if you're trying to get a complete picture, you probably would want to add at least the carrier file, as well as, of course, a denominator file. So that's kind of the bigger picture here, is that by understanding that things get routed into these different files because of different types of providers, different types of settings and providers, and the forms that they're using, and the types of services that are being provided, that means that you don't get kind of a nice, full, complete picture if you're just grabbing one of the files, usually. So much of the time, I would probably say most of the time, if you're assuming that you only need one file, you probably need to reconsider and check with us. Just different sources of information. Obviously, there are claims forms and instructions, claims processing manuals. Like I said, the processing manuals are actually really interesting. All the kind of guidance that's given on the on billing and processing and those kinds of things can actually answer some questions. There are questions that are in the weeds, but I mean, these are complex data, so you're in the weeds a lot. And so there's just some resources that you can use to kind of look through these things. Yeah, and manuals here from CMS. Questions? Let's see, it looks like people have been answering some.
Sorry, I just had moved up your your chat. There was a question about the common working file. If you could talk a little bit more about that.
Yeah, that's one that I haven't dug into as much. my understanding is that there is I don't know why it's written as beneficiaries assigned, because my understanding is that these are not multiple things, but this is one that I haven't dug into as much. I might, by after lunch or something, I might dig into that a little bit more, because I've spent more time looking at the max, because I think there probably is potential more variation on those. And it's more the outer facing part of the process. But I haven't really dug into the CWF host site yet, in terms of unpacking that as, whether there are multiple ones. I don't think so, but again, I haven't dug into it yet. So I'm not sure why we kind of phrased it as beneficiaries assigned, but I'm not sure that that's the best phrasing. So I'll check into that.
And let us know if we didn't clarify what an outpatient visit, a typical outpatient hospital service might be.
Yeah.
There was another question about how claims processing accounts for prior authorization.
Ooh. How it accounts for it. I mean, in some ways I could see prior authorizations as a reason for why certain types of services are not, maybe act as a potential disincentive. I don't know the degree to which it would actually shape the kind of actual the processing of it, because if the service is billed for and they had to get prior authorization, I would assume then that it's going to be processed through. I don't know if there's a field that actually captures that. I don't believe so. Steph, you know if there's any field that captures a prior authorization?
So I have not worked with one. There's a lot. So, well, at least in the institutional files, there are things like condition code file or value code file. That's probably where I would look for that, because sometimes those have sort of extra pieces as to how the claim was processed that are kind of outside of the claim itself. But yeah.
Okay.
There was another question about denominator file. What do we mean when we say that?
Oh yeah, I'm sorry. That's a general term meaning you need a file to kind of show you your denominator. Like, where do you get, how do you shape the denominator for your study? And so in that case, for the current name of the file would be the master beneficiary summary file segments. And so that's the actual name of that denominator file. So what I'm basically saying is, if you're going to do a study in Medicare, sometimes people will say, I just want the MedPAR, or I just want this file. And usually you're probably going to want to consider also asking for the master beneficiary summary file, the different segments of that. Just because, again, if you are running your study and you don't have as clean an idea as to who's a case and who's a control and those kinds of things, you're going to get that from the general term of denominator file, in this case, the master beneficiary summary file.
Thank you. And then I know we're running a little bit late to start our break. We can maybe answer one more question and then we'll come back at 11. But one question was, can the data from part A, B, and D be linked together using unique IDs? And then what might that be? what are there individual identifiers that can link?
Yeah, I mean, part D uses a Benny. I've only done a little bit with part D, but I mean, they just use a Benny ID, don't they?
Yes, yeah.
Yeah,
so all of the files, have a beneficiary ID that's going to be unique to the individual and link all the way across from the MBSF that you talked about to the claims to the part A, B, and D.
And I think and I think we'll talk about it later, but the beneficiary ID, one thing to keep in mind is that those are unique to each study. So it's not like you can just this beneficiary ID and this DUA that I did is the same as this beneficiary ID, so I can link them. That's usually not, typically what actually is, those are just issued and they don't tie to the beneficiary. So one thing to keep in mind is they might be linkable within a given study, but I wouldn't say it's safe to just say, oh, these are the same Benny IDs, I'm just going to link because I happen to have some part D. That's probably not going to work for you. So that's just one thing to keep in mind, but we will cover that too.
Good point.